Hypertension Awareness Series Episode 15. Secondary causes of hypertension and the tests to discuss them. Today we discuss when high blood pressure has an underlying cause. Good morning. Most hypertension is primary or essential, meaning there is no single identifiable cause. However, in some patients, high blood pressure is caused by an underlying medical condition. This is what we call secondary hypertension. And identifying the cause can sometimes dramatically improve the blood pressure and occasionally even lead to cure of the hypertension. Studies suggest that secondary hypertension may account for up to 10% of all hypertension cases and up to 50% in patients with resistant hypertension. Those are patients on 3 drugs, including a thiazide diuretic. So when do doctors suspect secondary hypertension? When hypertension occurs in the young, before the ages of 40. Blood pressure that is very high at diagnosis. You diagnose someone with pressures the first time over 200. The BP remains uncontrolled despite 3 medications, including a thiazide-resistant hypertension. Sudden worsening of previously well-controlled BP. Abnormal lab findings like low potassium. And these warning signs make doctors look for an underlying cause. What are some of the common causes and the tests that we use to detect them? Number 1 is renal parenchymal disease. This is the most common cause. Kidney disease is the leading cause of secondary hypertension. And when do you suspect it? Patients may have elevated creatinine, abnormal urinalysis, protein and blood in urine. They may have long-standing diabetes, or they even non-kidney disease and later develop hypertension, or even resistant hypertension. What are the tests that we do? We do the serum creatinine and an estimated GFR, urinalysis, urine albumin creatinine ratio, UACR, check the electrolytes, and for imaging, we do a renal ultrasound. Cause number 2 is renal vascular hypertension, what we call renal artery stenosis. Narrowing of the renal arteries reduces the kidney blood flow and activates the renin-angiotensin-aldosterone system, raising the blood pressure. When do you suspect it? Sudden onset hypertension below 30 years and over 55 years. Resistant hypertension, very important. Sudden worsening of the kidney function after starting your ACEs or ARBs. Recurrent flash pulmonary edema, abdominal blues. To diagnose this, we do the serum creatinine, plasma renin, renal artery Doppler ultrasound, and you can also do a CT renal angiogram or an MR angiography. Cause number 3 is primary aldosteronism, what we call Cone syndrome. Excess aldosterone leads to sodium retention, low potassium, and hypertension. When do you suspect resistant hypertension? Very important, hypokalemia. Early onset hypertension with family history of stroke. What do we do? Aldosterone renin ratio. Check your serum potassium where you have hypokalemia, and you can do CT of the adrenal glands. Cause number 4 is pheochromocytoma. We suspect this when you have the triad of headaches, palpitations, and sweating with high blood pressure. Other clues are episodic hypertension, panic-like attacks, resistant hypertension. The test for pheochromocytoma, you do plasma-free metanephrines. You can also do 24-hour urinary metanephrines. And for imaging, we do a CT scan of the adrenal glands or the MRI of the abdomen. Cause number 5 is obstructive sleep apnea, OSA. This is a common but frequently overlooked cause. When do you suspect OSA? Patients who snore loudly at night, daytime sleepiness, morning headaches, obesity, and resistant hypertension. So the test we do is called overnight polysomnography or a sleep study for the patients who snore. Cause number 6, Cushing's syndrome. When you have excess cortisol, this can cause hypertension, diabetes, and weight gain. When do you suspect it? This is in patients who have central obesity, they have moon face, they may have purple abdominal stria, muscle weakness, or diabetes with hypertension. Patients who have been taking steroids for other conditions. For the tests for Cushing's syndrome, we do 24-hour urinary free cortisol, overnight dexamethasone suppression test, and for imaging, a CT or MRI of the adrenal gland, or you can do pituitary MRI if you suspect Cushing's disease. Cause number 7 are thyroid disorders. Both hyper and hypothyroidism can cause blood pressure. For hyperthyroidism, you suspect with palpitations, tremors, weight loss. and even for hypothyroidism, fatigue, weight gain, cold intolerance. And for the test, we do the thyroid function tests, and you can screen with a TSH imaging, a thyroid ultrasound if indicated. Cause number 8 is hyperparathyroidism, which is missed very frequently. Patients with high calcium levels, this can contribute to hypertension. When do you suspect? In patients who have elevated calcium levels, patients who come with kidney stones, bone pain, and fatigue. And for the tests, check the serum calcium. You can do the parathyroid hormone, the PTH levels. Check the serum phosphates, and for imaging, you can do your parathyroid ultrasound. Cause number 9 is coarctation of the aorta. This is a congenital narrowing of the aorta causing hypertension, especially in young people. And you suspect it in a young hypertensive patients who have higher BP in the arms compared to the legs. You also have weak femoral pulses. So the test you do is just comparison of the BPs comparing the arms and the legs. You can do an echocardiogram and rarely a CT angiogram or an MRA. The key take-home message is that not all hypertension is primary. Secondary hypertension is often underrecognized, and identifying the cause leads to targeted treatment, better BP control, fewer medication, and sometimes complete cure. So you need to remember, not all hypertension is primary, and you need to check for secondary causes. Stay tuned for our next episode, episode 16, where we learn about hypertension-mediated organ damage, HMOD. We have said the hypertension is silent killer. It affects organs early before complications occur. So we need to know what are the damages that the hypertension causes in the organs and how we can screen that early. Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.